Hello and welcome to Noble Mind.
Noble Mind is a podcast exploring mindfulness, meditation, and psychology.
Hello, Noble Mind listeners. We are so excited to share our latest episode where we talk to Dr. Akeem Sule about his work with people experiencing psychosis and other severe mental health symptoms in an inpatient setting. He discusses the potential pitfalls of a purely biological view of mental illness and describes some therapeutic interventions that he's found useful. We also talk about the pros and cons of mindfulness and discuss his passion for exploring the mental health themes in hip-hop music, film, and television. Dr. Akeem Sule is a consultant psychiatrist for the National Health Service in the UK. He's engaged in research and received multiple awards for his teaching. He's also co-founder of Hip Hop Psych and gives lectures on mental health themes that appear in film, TV, and music. As always, if you love Noble Mind, you can follow us on social media. That's on Facebook, LinkedIn, Instagram, Twitter, YouTube. You can even join a free Facebook group at facebook.com/groups/NobleMind and check out our website at noblemindpodcast.com. You can hear about upcoming events, get show notes, and join our email list. Enjoy the show. Hello, and welcome to Noble Mind. We are here today with Dr. Akeem Sule. Welcome to our show. Thanks so much for being here. Maybe you could say hello to our listeners and tell us a bit about yourself.
Okay, so hello, listeners. I'm really excited to be here, Noble Mind. So what should I say about myself? Well, I'm Dr. Akeem Sule. I'm from Nigeria in the house. I am what you call a consultant psychiatrist. So what that simply means is I've completed my training in psychiatry. I work in the UK. I actually work on an inpatient psychiatric ward, a female psychiatric ward to be precise. Treat lots of patients, often at the severe end of the spectrum. So patients suffering with varied presentations, depression, anxiety, psychotic disorders, bipolar disorder, addiction, severe anxiety, severe obsessive compulsive disorder. I'm also an honorary visiting research associate with Cambridge University Department of Psychiatry, and I'm also a research associate with Wolfson College, Cambridge University, and I'm also the co-founder of an organization called Hip Hop Psych, and I love hip-hop music, and I love film. Yeah, that's me.
Welcome.
So many possible directions we could go here. Let's dive in maybe to telling us a little bit about maybe your approach to therapies and kind of how you think about the sort of work you do.
Okay. So just to say, so I'm a psychiatrist. I work on an inpatient ward. Now, on inpatient wards, like I said, a lot of the approach, I've got to be honest, tends to be biological. So what that means is because they're severe, you tend to treat a lot with medication. And if you're not careful, your explanatory models tend to be very biological or medical. And generally, that means patients potentially lose out. Now, I must say we work with a multidisciplinary team. So that means we do have psychologists, we have occupational therapists. We even, on my ward, we have a movement psychotherapist as well coming to the ward. But as a psychiatrist, since you tend to be the responsible clinician, it's really important you have a biopsychosocial model of management and explanatory models. So often, I often ask myself, when a patient comes in with depression, if you're not careful, a lot of your explanations tend to be something like this. You've got depression and the classic, this must be a chemical imbalance in the brain. Your serotonin is not right. And we could discuss the controversial umbrella review by Joanna Moncrief, where she basically queried whether that was the case. And then the psychiatrist shot back with the leaky umbrella review, punching holes in a study. But I think when you present that to a patient or psychosis, there's excessive dopamine. The patient says, okay, doctor, that's all well and good, but I don't understand why my depression started after I left my partner. Then you have one of those oops moments, you understand? So I think you need something which is holistic. I tend to try and bring some of these elements in. So for example, let's take something like depression. And I'll try and give some case examples.
Right.
Not necessarily for patients I've seen, but generally capture the spirit. So let's say you have someone, let's call him Steve. Steve is a medical student. When Steve was very, very young, his parents weren't good to him. He had what you call adverse life experiences. His parents were abusive, emotional abusive. They would say to him, "You're never going to amount to anything." They were criticizing him. And in cognitive behavioral therapy, and I know, Katie and Alex, I know this is your baby, so don't need to patronize you. You have core beliefs. So the core beliefs are things like, I'm unloved, I'm a failure. And then often what you have is a kind of schema. So this is a way of thinking. So the person says, except I'm successful in everything, I'm a failure, I'll be unloved. And sometimes that schema helps them. These are called dysfunctional assumptions. And they work to an extent until you have what in cognitive behavioral therapy is. And this is a type of treatment, evidence-based treatment for treating depression, where you have a critical incident. So the critical incident is the medical student is passing everything. Then all of a sudden, bang, they fail their anatomy. That's the critical incident. Then you have what in the UK, I don't know if in America, they call it the hot cross bun model, where you've got dysfunctional thoughts, where you have thoughts like, I'm a failure because I failed my anatomy exam. That leads to emotions of you feeling sad. You might feel a bit, have physical feelings. And then the behavior is to socially withdraw. And when you socially withdraw, what happens? That makes you sadder. Then you have more the negative thoughts. And sometimes pointing that pattern out, which you can do in a quick word round, can be very helpful for the patient. And you can even do some behavioral activation where you basically ask on a scale of 0 to 5, tell me about your most pleasurable activities, map that out over the day, and look at activities that give you a high sense of achievement. And the rule is the more activities of pleasure and achievement you do, your mood gradually improves. Or you could do like a thought diary where you challenge those negative automatic thoughts. So you could ask them, okay, on a scale of 0 to 10, how much do you believe that you're a failure because you failed your anatomy exam? They say 90%. You say, okay, so how many people get into medical school? Is it easy? And you begin to swing it. And if you have an impact on thoughts, you have an impact on emotions, and they get better. These are things that you can do in a quick word round with your patients. Other models I find helpful is interpersonal therapy. Love this one. Developed by Klerman, Wiseman. Very good in depression. I don't know how much you use it in the States, but 4 domains. We talk about grief, which is loss of a loved one or object. And it's mainly on interaction. So there's role dispute, role transition, and there's interpersonal sensitivities. Now, why I like this one has to deal with relationships. So I hope the audience can say relationships with me, okay? So you have a patient, let's say legal secretary, let's call her Emma. Emma looks at her boss, who is a lawyer. They look at each other, they fall in love. So I like the story. We always have to have the story. They fall in love, and then they date. After some time of dating, unfortunately, her lawyer boyfriend, let's call him Steve, says to her, you know what, you deserve someone better, and ends the relationship. So let's look at how those 4 domains help. 1, there's grief, loss of a loved object. There's a role transition. So she's gone from being an employee to being a lover to being jilted. So that could cause one of the reasons for depression. Then there's a role dispute, because how do you go from being a lover to being an employee again? And the 4th one is interpersonal sensitivities, because there's definitely going to be beef. There's going to be stuff. And sometimes pointing these domains out to the patient, again, in a quick word round, doesn't need to, and I'm not saying I'm going to be delivering the treatment, but you could say, have you noticed, look at these 4 domains. What do you think you can do about each of these domains? Very, very good way of dealing with things, okay? I'm just going to give a few more. Another one I find very helpful, and I'm bringing this one up because I know you're into your mindfulness, Katie and Alex, and I wouldn't be doing justice if I didn't mention. So there's this concept called overgeneralized autobiographical memory. So this concept, there's a professor in Oxford called Professor Mark Williams. And basically what he said, there's this belief that when people are depressed, there's a focus on negative automatic thoughts. We know that in cognitive behavioral therapy. Mark Williams, what he says is that there's an overgeneralized autobiographical memory. So these autobiographical memories tend to be about things. So if you ask them, what's the most positive thing that's happened to you. Often, if you ask anyone, they'll say, oh, it was the day Manchester United won the Champions League. It was on this day John Terry missed the penalty. For those of you who, the Champions League is a soccer, as you say, we say football in the UK. So you can give a specific time date, very specific. But if you say, what's the most negative thing you have? For me, it might be, oh, it was the day I failed my anatomy exam. I'm not the guy described in the CBT case I gave, but you can give a specific example. If you ask a depressed person, what's the most positive thing that you've experienced? They can't give you specific. They will say things like, oh, it's going out. So no date, no time. So they can't get the juice out of that positive experience. And when you ask them, what's of that the most negative thing in your life? They will say things like living. So not specific. So we know that people with an overgeneralized autobiographical memory are more likely to experience depression. And so there are tasks you can do. Now, you can do metacognitive training, which is thoughts about thoughts. Or the funny thing, changing those overgeneralized autobiographical memories can help to improve the depression. And actually, mindfulness training does help. We're going to come back to mindfulness because I've got my thoughts about mindfulness. Mindfulness for cognitive behavioral therapy has good evidence, particularly when people have recurrent, like 3 or more episodes of depression. We know it's good for that, but it's also very good for other things.
Yeah, this stuff is so useful and important. Even just kind of going back to what you initially said, which is that being in an inpatient psych facility, there's so much focus on the biological explanation, for people's mental health difficulties. And that can be really disconcerting for patients and their families, looking for real meaningful help. And then, you sort of show up and, if people on the unit aren't really being thoughtful to be more biopsychosocial in their thinking, then it can be really reductionistic and invalidating for people. So that feels like really important to highlight and also just to validate if people have had that experience. And sometimes even just going to a medical doctor or a psychiatrist, even outside of an inpatient unit, people can fall into that sort of reductionistic thinking. So I love that you're bringing in CBT and interpersonal therapies and other, ways of thinking and conceptualizing and trying to help people take some agency back, with things that they can actually maybe do or improve, in their own kind of life rather than just take a pill and hope for the best. Yeah.
So which brings me on to psychosis. So psychosis is always an interesting one. So let's start with Jaspers. Jaspers is in psychiatry. Jaspers is a phenomenologist, really good at describing psychotic experiences. But there's one thing he says about psychotic experiences, particularly delusions. He says delusions are ununderstandable. And I've got to tell you one thing, that is a lie from the pits of hell. Okay? Because by exploring hallucinations or delusions, it gives you an understanding of the patient's world. Now, what I'm going to try and do, I'm going to start with something very, very biological, and we're going to spin into more psychological concepts. So just bear with me. I'm getting excited, Alex and Kate.
And this is a great example, just to kind of touch in with what you're saying. This is a great example of how people show up to something like psychosis with a strictly biological explanation, and now you're going to say, not so fast.
Okay, absolutely.
Yeah, okay, lay it on us.
Let's think about psychosis. Simple thing is delusions and hallucinations. How do they develop? There's an excessive production of dopamine. We've got some research, Oliver House, PET, Dopa scans, all that. Okay, what does dopamine do? Dopamine is a neurotransmitter. To lay people, that's a chemical that codes for salience, which means when my dopamine is produced normally, I know things that are important. Now, when dopamine is produced excessively out of sync, we have what is known as the aberrant salience theory of psychosis. What do you mean? So dopamine is termed the fire of psychosis. So then things take on a meaning, they're important. So I'll give you an example. I am looking at a white van outside. My dopamine is being produced normally in my striatal area, which is an area of the brain. I say, white van, very interesting. But when the dopamine is being produced excessively, that thing takes on a meaning. It's important, it's important, it's important. Why is it important? Then all of a sudden, I have what is known as, some people call it Truman sign. If you watch the Truman Show, so remember the Truman Show, spoiler alert, Truman sees these coincidences. He sees the twins, he sees this thing. And he knows, you know what, there's something going on. And then bang, he has the eureka moment, which we call delusional insight, where he says, I'm in a TV show. Spoiler alert, in Truman's case, he is actually in a TV show.
Right.
But it's a bit like that, where your senses become heightened. Now, what's interesting is I see the white van and then bang, my aberrant salience, dopamine being produced excessively. And that's what most antipsychotics do. They dampen down the dopamine signal by blocking the dopamine receptors. But then I say, that van outside is by the MI5, and I suspect they're using artificial intelligence to control me. Like, what?
Mm-hmm.
You have that moment. Now, let's take what Jasper said. Jasper said delusions are ununderstandable, but let's challenge that. Why is it that delusions involved? So I'm from Africa. So when people have delusions in parts of Africa, sometimes it can be about witches, often steeped in religious beliefs, okay? Why is it that now you're seeing more delusions on artificial intelligence? We didn't have those beliefs. Back when you had the Cold War, you had delusions about Russia, the CIA, the KGB. So we know delusions the content has evolved over time. So that challenges that basic premise about delusions being ununderstandable. Now, the question is, what does that delusion think? So if we have aberrant salience, so aberrant salience about what? So it's about our thoughts, about our emotions. And this is where things like psychodynamic psychotherapy, ways of thinking can come in. Now let's go back to Freud. Let's go back to Scriber. So there's this interesting guy called Scriber. I believe Scriber was a judge. He did these annals on basically talking about his experience of psychosis. He believed his doctor was gradually murdering his soul by changing his body into a woman. So Freud comes on the scene. Freud in 1911, without seeing Scriber, writes this psychoanalytic, there's actually a book he wrote on it, where he basically spoke about how this represented some repressed libidinal urges. And he described the delusions as a sticky plaster. So he sought to understand these delusions. And remember, I've gone from the biological to a more psychoanalytical way of thinking. But he said it was a sticky plaster. So he sought to understand the meaning of the delusions. However, Freud surmised that going into psychoanalysis due to transference will lead to further regression, basically saying psychoanalytical treatment would not be helpful, which I would just say generally I agree with it. But you know, Jung, now I'm not going to go on about Jung and Freud and whether they had beef. Jung had the opposite. Jung basically said, what? The delusion is that expression of creativity and spirituality, but it's possible that the answer is basically somewhere in the middle. But what's also interesting is when we look at psychosis, let's look at how psychological concepts have developed. So back in the day, we had this theory about appraisal, that psychosis, when we have delusions, what happens? So you have a delusion, you have an appraisal, and often the appraisal is what causes the anger, the anxiety, and the shame. So the anomalous experience is the CIA after me. I see that as threats. My emotions, I become angry, I become a bit ashamed. But what does that make me do? That makes me to do safety behavior, avoidance behavior. So I stop going out, I'm constantly checking, and we know how that feeds back. Again, the hot cross bond model, like we like to say in the UK, you should have a look at the hot cross bond model. You actually see, you know that diagram, nice diagram you have, where that feeds into more paranoia because you're not going out, you're not disconfirming the evidence. And so these are some of the things, discussions that you can have with the patient. Other interesting cognitive behavioral therapy concepts, jumping to conclusion bias, which Garrity spoke about. So this is a tendency for patients with psychosis to jump to conclusion. And there's an interesting experiment where you put beads in a jar and you can make it 80 black beads, 20 white beads. Anyone can see that after, then you shake the beads about. What we know is that patients with psychosis, when it's like 60-40, most healthy volunteers will be less unsure. But patients with psychosis, after a few beads removed, we say it's definitely black is more, really. So the theory there is that people with psychosis tend to jump to conclusion without trying to look for disconfirming evidence. And there are actually therapies you can do to work on that. So these are, I'm not saying I would do that in my ward round, but these are some of the things you can talk about, especially when you're treating and the patient is getting better, for them to have an understanding of what's going on. Now, back to more psychodynamic theories of psychosis. I want to get into this. We've not spoken about defense mechanisms. What about things like projection? So we know defense mechanisms are unconscious mechanisms. When we have a conflict, an unconscious conflict, sometimes where we talk about feeling very, very angry, but due to our upbringing, we are not allowed to manifest it. Sometimes that could be projected out, and then I see someone as persecuting me. It can also happen with psychosis when there's a lot of trauma. So people are very upset. They have a harsh super ego, which is criticizing them. And a harsh super ego can also explain why people hear voices which are often critical. Which leads me to another interesting one, manic defense. We sometimes say, when the CIA are after me, maybe it's because I have low self-esteem. But let's flip it. What of when you have a manic defense? So a manic defense is an unconscious mechanism where I try and compensate on an unconscious level for my perceived feelings of low self-esteem by basically amplifying things. So CIA can only be after me if I'm relevant. Isn't that very interesting? So if I have a low self-esteem, sometimes that delusion is a functional delusion. And psychologists, especially cognitive behavioral therapists, sometimes they ask patients, so if you woke up one morning and the CIA was no longer after you, how would you feel? The person will say, much as I don't like them being after me, I feel like life isn't worth living. So sometimes what cognitive behavioral therapists will do on the ward is they will give a self-esteem rating scale and then work on the self-esteem as we treat. But these are some of the things to talk about manic defense. It's easier for the grandiose ones. If, for example, I believe I'm married to Rihanna.
Maybe you are.
Rihanna, by the way. You understand? That's an obvious manic defense. But sometimes even the so-called persecutory delusions are evidence of manic defense. Now, I would be doing myself injustice if I didn't talk about acceptance and commitment therapy and compassion-focused therapy.
Gotta have those. I mean, this is Noble Mind, so.
Okay, so we gotta. So how could that be relevant in my practice as a busy inpatient consultant? So we've mentioned that in psychosis, you can have a lot of self-critical voices. You can have a lot of blame, low self-esteem. So there's this concept that what tends to happen is that the self-nurturing self can actually be switched off. And so sometimes we need to reactivate it. Now, think about it. On one hand, you have a patient who's being persecuted, who has low self-esteem. So maybe their self-nurturing self has been deactivated. So what you feed grows and gets bigger and bigger. So if you feed the self-nurturing self, it could help with things. So the theory then would be that in my inpatients, you could say to them, okay, let us try and create an image of a self-nurturer image. What would they be like? What would they say to you? And you're basically training them to feed the self-nurturer. Sometimes you can do it by getting them to visualize. And I'm sure Alex and Kate, you know that a lot of the work now, they're working on images. Before it was just thoughts, but now there's the whole visual imagery. I don't have time to talk about that. If time I can come back to Emily Holmes' work on positive visual imagery, but just stay with me. The other thing you could do is get them to write a compassionate letter to themselves, where they really write a letter and give themselves compassion. And you think that over time that would help. But these are treatments. The evidence isn't really brought that much in psychosis, but it would do no harm and it might help. The same thing with acceptance and commitment therapy, where basically the person accepts, I have delusions, I have voices, but rather than shouting at the voices, trying to suppress the thoughts, let's keep that moving and let's focus on what are my positive values. My positive values are, I want to listen to hip hop. I want to go back to my All Eyes on Me, Tupac Shakur, CD and listen. I said CDs, shows how old I am. I want to stream on Spotify that. And the more you do it, again, what you feed grows, then hopefully that has an impact. Again, these are areas that one can look at, and I think that they potentially can be helpful. Other things we know work, family therapy. So we know of the work of Vaughn and Julian Leff. where we noticed that there were three things that led to relapse in schizophrenia. They were hostility, critical comments, and over-involvement of the family. And apparently, if you worked on those three, in addition to medication compared to treatment as usual, it actually helped to reduce the chance of relapse. So there are all these very, very interesting things that you can deal with. Oh, okay, so that's me on psychosis. I'll take a break now.
Let me jump in. Catch your breath.
Yes.
It's such a great overview of something that a lot of people, I think, just hear psychosis or think psychosis and just assume it's intractable, it's impossible. This person, I can't relate to this person, and it's just such a nice, like, just brief download of like, no, here's like 15 other things that you can do to help people. You can help people develop their self-esteem. You can help people be more self-compassionate. You can help work with people's families. You could maybe do a little cognitive work around the edges. Just because you can't directly change the dopamine levels or get rid of the psychosis completely doesn't mean it's a hopeless cause. So I think that's a great message of hope that you've shared there. And I know is also just useful more broadly, again, outside the inpatient unit.
Absolutely.
Yeah. So you did mention an interest in telling us some of your thoughts about mindfulness. Might this be a time to dig into that?
Mindfulness is good. The evidence is there. Mindfulness, CBT, I've mentioned it, is evidence in depression and also for stress management. But we also, I think, sometimes what worries me about mindfulness is when they want to create this notion of it's a panacea for the world's problems. So I'm not sure if you're aware, sometimes there's been this commodification of mindfulness. There's a concept called mindfulness. I don't know if you've heard of it.
Yes, that's a book title, I think, right?
Absolutely.
Yes,
so this concept that mindfulness is sold like McDonald's in UK, some parts of the UK, we call it, we call it Mackie D's, you understand? Where you have a McDonald's in every corner, you go to Tibet. And so I always get suspicious when these mega companies are training their workers in mindfulness. Because the question is why? To make them more productive or to make them more resilient. And my view is, why not improve your conditions? Or where you have situations where apparently combat soldiers are taught mindfulness. Why? So they could go on killing more people.
Right.
Which worries me about the ethical. So we always have to think about ethics. Who are these psychologists, whether they're organizational psychologists? Is it really about well-being or is it about something else? So again, I'm just saying it because mindfulness does have its benefits, but let's be mindful. Then there's this very interesting study called Myriad Study, and it stands for My Resilience in Adolescence. So it was conducted by a team from Oxford. There's a professor, William Cookian, as one of the authors, and Mark Williams, whom I mentioned about overgeneralized autobiographical memory. And what they did was they investigated a brief school-based mindfulness intervention to support mental health in young people in secondary school, aged between 11 to 16, because they felt this group, and I'm sure in the States too, are increasingly vulnerable to mental health problems in the UK. So what did they find? So they sent it out. It spanned ages 2015 to 2023, 28,000 students, 650 teachers, 100 schools, and 20 million data points. The mindfulness training was provided by teachers. What did it show? Guess. Did it work? No, it did not work. It did not actually improve the well-being of the students. Now, what was very interesting, there are a few caveats. It wasn't necessarily co-designed. The teachers were given the therapy. But generally, the young people, what they said, when they were asked on one occasion, what question do you think we should ask? They asked the students, who can you turn to if your well-being is affected? So we've got to think about a thing like that we know works in adults. How, imagine spending tons of money on school children only to find out it doesn't work. And I really thank the authors for publishing it because it shows us about being mindful, improve the conditions of workers. And I must say, in the UK where I work, sometimes people give out mindfulness cases. And obviously, we've got to think about junior doctors in the States, we say resident doctors. If they're working in horrible conditions, mindfulness isn't going to fix them. And in that particular study, they spoke about the importance of looking at poverty and social determinants of mental health. I'm sure that's quite a big thing here. that they're teaching on. So we've spoken about biopsych, but let's not forget social, economic deprivation, those kind of things, because we know, for example, in treatment-resistant depression, they're more likely in people from social, economic, deprived backgrounds. So we need to think about those things and not just use mindfulness there. The next thing about mindfulness is how it's perceived. Obviously, some people, and we've got to look at those people outside, believe it's from a Buddhist origin, so they might not necessarily be keen on it. When you talk about mindfulness, the way I look at it, mindfulness is the philosophy. Meditation is one of the keys to achieve mindfulness. But in the Bible actually, and I'm a Christian, so my background is interesting. My parents were both Muslims. They've done the Hajj. For those who the Hajj is where you go on that pilgrimage to Mecca. They've both done it. I converted to Christianity. But in the Bible, it does talk about meditating. So there's a place in Joshua where it talks about meditating on the word of God, that you should meditate. And the process of meditating there is more of a contemplative stance where you basically chew on the word of God. But there's also a part in the Bible where it talks about be still, for the presence of the Lord is here, where it talks about waiting, which I guess would be a bit similar to mindfulness. So when we're talking to different groups, and what I'm saying doesn't apply just to Christian, it could apply to people in Judaism and people in Islam. They might be a bit worried about mindfulness in terms of its Buddhist origin. So it's important to find out what they want, and what kind of mindfulness they're willing to look at, really. That also reminds me, because there's this chap called Koenig. He's a psychiatrist that is interested in religion and psychiatry, and he's produced this metacognitive therapy manuals. You should go and check it out for different religions. It's so interesting, super interesting,
Wow.
like for Buddhism, for Islam and Christian, and it brings those scriptures there.
Yeah, I think that's great. Totally on board with everything you're saying in terms of the way that mindfulness gets misused in sort of corporate cultures in particular, and they ignore the broader working conditions and they try to just patch it up with a wellness day or some mindfulness consultant or something when there's much larger issues at play. So yeah, I think that's just really important to highlight. Yeah.
And tying that to something we were discussing with Akeem before we started recording, which was the systemic causality, the 10,000 causes of, we were seeing how you face people struggling with suicide and, the last ditch defense.
Yeah, sometimes it feels like that.
Yeah,
yes.
yeah.
Because economic factors, social factors,
Absolutely.
education, healthcare,
yes,
intergenerational trauma. There's so many things, and you're there with your finger in the dam, trying to, or all 10 fingers in the dam.
Yeah.
Okay.
Yeah.
You know what, Alex? When you throw words like intergenerational trauma, now don't set me up. But that's so interesting, because again, we can think. I'm just going to throw a few ways of thinking. So we basically think about how that has an impact on culture. So there's some interesting, this is very biological. Let me just throw that in for biological guys. There's an interesting study by Yehuda where she studied intergenerational trauma. She basically looked at some receptors, genetic work on some receptors related to the stress pathway, and found out that in children of people that survived the Holocaust, even when they were removed from that area, they had a change in those particular areas. So biologically, that trauma can be passed down. Although you've got to think about things like vicarious learning. So again, it's not always about the genes and vicarious learning. And we can talk about the legacy of slavery as well, which is something that people don't want to talk about really. Among African Americans, we can talk about the legacy of intergenerational trauma and the legacy of Jim Crow and how that has affected incomes and how that can lead to mental health problems. So there are all these social determinants of mental health that we need to be basically looking into.
Absolutely. And that idea that some of our listeners may or may not be familiar with of epigenetics, which I think is what you're getting at, right? Where
Definitely.
like which genes get activated in a person, has to do with the genes activated. This is like Kate's very simplistic explanation, in one's parents and grandparents and so on. So, so the wiring that you have, or like what genes are going to be active, just from your day of birth, or even during gestation, are going to be impacted by the conditions of your parents and grandparents parents and then over your lifespan. I mean, you have some control over some of those levers, but in, when social conditions are not good, it's a setup.
Absolutely. Yes. And so since we're talking about it's not all in the genes, sometimes there's an opportunity for trying to deliberately choose protective environments. So, for example, I might come from a family where there's a history of diabetes, stroke, heart attacks. So I know from the jump that I've got to exercise. So I might deliberately choose protective environment. So I'll make sure I join a sports club, a football club, a soccer club, deliberately choosing that. Or if I come from a family where there's a family history of schizophrenia, then in terms of trying to reduce it, I might deliberately choose protective environments. It could help, So I definitely won't be going on the cannabis. I might basically go to church, and try and find ways to reduce stress, make sure my social connections are rich. So there's something about trying to choose protective environments. It's not always easy against social determinants of mental health, but these are some of the things where it just gives us that sense of agency.
Absolutely. If there's anything you can do that might even make a 1% change,
Absolutely.
then, it can create a feeling of at least having some influence,
Yes.
So much great information here. So much great input. And thank you for referencing. And we'll put links to those articles and authors in notes.
I'd love to hear about your Hip Hop Psych work.
Yes, with Hip Hop Psych, it's a joint venture. And it started with me. I trained in Nigeria, massive hip hop fan, been listening to hip hop since 1979, Sugar Hill Gang, all that, up until my favorite rapper is Tupac Shakur, even up to now. Kendrick Lamar is probably, but I joint venture with my colleague, Dr. Becky Insta. We basically analyze hip hop lyrics and we comb them for mental health themes. And we cover everything. Tupac, lots of social commentary, really interesting because his mother was a Black Panther that actually defended herself in court, but she also ended up having a crack cocaine use dependence. So with Tupac, you get both worlds. You can get the most unfortunately misogynistic stuff, but you also get the most Black Panther empowering stuff, really. So a very complicated person, but there's also like the wave of emo hip hop. So this is influenced by hip hop or emo punk, where they're basically talking about, so people like Juice WRLD. So we've written about that, but I've been doing more stuff on films and TV shows, which I'm really recently published on The Wire, my opinion, the greatest TV show, which again, in terms of social determinants of mental health, good. Published that in Lancet Psychiatry. That was really good. And recently in the UK, we've had Top Boy. Top Boy is like really good, really does with social determinants of health. It's a bit like and again, this is like doing it a disservice, but to give a point of reference, it's like The Wire, but in a UK sense, but it really talks about social determinants of health because you see how people enter gangs and how that increases their risk of developing mental health. Now, there's something very interesting. There's a character there called Sully, who would be very similar to Marlowe in The Wire, but Sully has an incident, again, spoiler alert, where there's racism. His friend gets there's an arson attack on where they're staying because they're refugees there, and as a result of that, he clearly develops symptoms of post-traumatic stress disorder. There's a scene where he's having vivid reliving. He actually feels his hands are burning, and he can smell smoke. If you're not careful, you think it's an olfactory hallucination. It's not. It's basically symptoms of flashbacks where there's a vivid recollection of what happened. And he actually is hyper-aroused. So he's often hyper-aroused. And we know when you're in those kind of neighborhoods, and especially in UK where, to talk about knife crime, if you're in a neighborhood where due to social deprivation, there's crime, neighborhood disruption, then you're more likely to hold a knife and sometimes it's anxiety. Some of these people have post-traumatic stress disorder and he basically removes himself from the environment. So these are very subtle, but with my psychiatrist's eyes, I can pick some of these things up.
What have you noticed, if you have noticed, changes in how mental health difficulties are portrayed in film and TV over the years?
Okay, so let's go to One Flew Over the Cuckoo's Nest.
Yeah, good place to start.
Yeah, as a psychiatrist, that did a disservice to psychiatry.
Totally,
So
yeah.
Jack Nicholson's and ECT. Now, I know some would say ECT is controversial. I work on the inpatient ward. I've seen it do wonders when people are severely depressed in the right patients. But when you speak to the older generation, you often have to correct that impression that ECT isn't about that. It's not to torture you. It works. You know, they're muscle relaxants. There's a good evidence base. So I think there's a increased sophistication, but sometimes even in modern shows, like, is it 10 Reasons Why? You know, that Netflix show on adolescent suicide.
Suicide, right, yeah.
Yes. You know, there's the risk of the contagion effect. So when it's not portrayed well, now some of my patients, and I ask them, you know, some of them find it helpful. It's nice to know I'm not alone. But then we know that there was an increased searching of pro-suicide websites after people watched the TV show. But some people get it right. So, for example, I like In Treatment, particularly season 4. And you know why I like season 4? There's a Black psychotherapist. We know.
Nice. It took them till season 4? Jeez.
It took I know, but we've got my sister in there. But it's really interesting because what's very clever about season 4 is we have a Black psychotherapist who is not a mommy character there to comfort white folk. She's there to address issues. They talk about racism because I've had situations where psychotherapists, when racism is mentioned, they come up with it's projection, you know, the whole stuff. But the fact it's acknowledged. In Atlanta, there's a scene where I just called Donald Glover's character. I've forgotten, I should know his name, but where he opens up about abuse, and as a Black therapist, he feels able to open up to abuse with a Black therapist and to talk about racism, where he's falsely accused of stealing something. So you see powerful moments when you have Black therapists engaging with other Black therapists. We also see that in I May Destroy You, great TV show by Michaela Coel. And what's interesting there is she's quite loud, but sometimes when Black women go to therapy, they're toned police. They're saying, oh, you're too loud, and stuff. Right. So these are the conversations we can have. And TV shows, I think, generally have a role in doing that. Shutter Island is a very good one. If you want an example of a game, we're talking about psychosis, Teddy, and how, again, talking about that whole idea about aberrant salience and psychodynamic themes, definitely one to watch. And I can't forget Beef. TV show Beef, fantastic show, love it. It's about Asian Americans, and the two characters there, they talk about subconsciously that depression is a state of anger turned inwards. They're definitely depressed and they take it out at each other in rage and a lot of anger, but subconsciously. But there's a mind there where someone realizes he's depressed and tells him to go for therapy, and he says Western therapy doesn't work on Asian minds. And that, for me, that was the most powerful thing about the show. We definitely strongly recommend it.
Yeah. We'll put your viewing recommendations on our show notes page.
Yes.
I've heard you speak about The Sopranos too.
Yeah, guys, you have to put a link on The Sopranos. The Sopranos, again, after The Wire, the greatest TV show ever made. You have this New Jersey Italian-American boss, hard as nails, but you see his vulnerabilities. Again, with a psychiatrist who takes a biopsychosocial approach. She treats him with an antidepressant, augments it with lithium. She looks at some of the themes, like the origins of his panic attacks. For example, the ducks fly away from the swimming pool is his fear of losing his family.
Right.
She interprets a dream where this dream is interesting. His mother tries to kill him, and then he has a dream or a dissociative episode or whatever he has, where he sees this beautiful woman, and Tony Soprano is very promiscuous. He likes her platonically, but she's extremely beautiful. And there's a scene where this woman is breastfeeding him, and he sees it coming in to the dream. And when he asks the name of the baby, it's Tony. So it's basically a symbolism of the mother he wants to have, the nurturing mother. Again, we've spoken about self-knowledge. Yeah.
Dr. Melfi was good with dreams.
She was so good.
That was the psychiatrist's name. Yeah.
Also, the ethical dilemma. Again, we spoke about mindfulness. Treating Tony Soprano makes him an more effective killer.
Yeah, right. Do you have any thoughts about media representations of therapy? Like Dr. Malfi is a good example, but also like real therapists. There's an increasing number of podcasts and TV shows where people, like real people, get therapy from real therapists, and it's used for entertainment. I don't know how I feel about that.
Yeah, I don't know. It's we have to be careful because it's privilege. And the question is, who are you treating? Are you trying to make a show out of it?
Right.
I mean, the podcast you're doing is highlighting these things. So why do you need to stick cameras in it, really?
On the one hand, increases awareness. On the other hand, if it feels iffy to me. Yeah.
Yeah.
I think there's a show in the UK called Couples Therapy, Channel 4.
Yes, I haven't watched that.
I find it difficult to watch those as a therapist myself. Yes. It's just not what I want to do on the weekend.
You probably would cringe, isn't it? You know, you would cringe.
This has been a wonderful whirlwind of all sorts of ideas and perspectives. Thank you for sharing your considerable insights with us and on a wide-ranging topics.
No, thank you for having me. Thank you.
If people want to get to know you better, see or hear more about your work, where should they go?
Okay, follow me on Twitter, formerly now known as X. We need to have a conversation. I know.
I'll follow you.
Yeah. Because from there, then once they DM me, then we can have those kind of conversations, really.
Great.
And we'll put a link to your other podcast.
Yes, because I'm really keen on public awareness. And that's why, like I said, the X does have help in disseminating that, really.
Yeah.
Yes, most of it.
And my Twitter handle is, I hope it's at AK411CAM. At AK411CAM. And just interesting, the 411 comes from the Mary J. Blige song, What's the 411?
That's
nice. A really good track.
Great.
Featuring Grand Puba.
Great. Thank you so much for sharing. This has been great. Really appreciate your time and your perspective. And that's it. Thanks so much. Bye-bye.
Okay, thanks. Bye.
Thanks for listening today.
If you enjoyed this episode, we hope you'll hit subscribe, leave us a great rating or review, and spread the word. You can also go to noblemindpodcast.com to join our email list. You'll get a weekly behind-the-scenes message, news, announcements, and other special goodies we come up with just for you. Thanks for listening, and bye for now.